My name is Debbie Zanis, and I'd like to welcome you today to our OPSI audio conference series on reduction of insulin-related adverse events. We have sent out the handouts, so you should have received them, along with the attendance sheet and evaluation sheet. Please follow the instructions to sign in on the attendance sheet, and please complete the evaluation sheet at the conclusion of the program. And we will need to receive those back in order for you to receive your continuing education credits. Pharmacists, there are special instructions on the attendance sheet, and I want to call your attention to that and ask that you follow those instructions. I want to welcome our speakers today from Nationwide Children's Hospital, and they were chosen to speak as part of our OPSI audio conference series. They did submit a best practice application, and it was scored very highly, and we are very, very proud of the work they are doing in the state of Ohio to reduce insulin-related adverse events. I'd like to tell you a little bit about our speakers today. Dr. Camboge is the interim chief of the section of endocrinology in the Department of Pediatrics at Nationwide Children's Hospital and an associate clinical professor of pediatrics at the Ohio State University College of Medicine. Dr. Camboge did residency and fellowship training at the University Medical Center Bellevue Hospital in New York. Additionally, as an endocrinologist, extensive experience in clinical management of multiple endocrine disorders, including disorders of growth, puberty, adrenal gland, thyroid hormone, work with diabetes mellitus. And also, Dr. Camboge is the Director of Quality Improvement for the division at Nationwide Children's Hospital and is involved in multiple quality improvement initiatives for type 1 diabetes. Our second speaker for today is Erin Ahrens, and Erin is a registered nurse involved in clinical informatics and is a clinical informatics application engineer within the clinical informatics team at Nationwide Children's Hospital. The primary focus is quality improvement and medication safety initiatives, and also working with the electronic health record to migrate clinical errors. Erin is trained and certified in several EPIC system applications to include EPIC Ambulatory and EPIC Inpatient. Our third speaker today is Jenna Morandi. And Jenna is a pharmacist, and she is the medication safety coordinator at Nationwide Children's Hospital, and also the Health System Pharmacy Administration Residency Program Director. She is involved in medication safety within the pharmacy department at the system level and works closely with interdisciplinary teams and frontline staff to identify individual and system-based interventions in order to prevent medication errors from occurring. She focuses on many initiatives, one of which included reduction of insulin adverse drug events and decreasing immunization errors. Jenna has served in a safety role for the 13 primary care clinics, as well as works with interdisciplinary teams to reduce medication errors in the inpatient and outpatient environment. Now that we know a little bit about our speakers for today, I want to thank them for volunteering to do this presentation, and I'm going to turn the talk over to them. Thank you.
Thank you very much. We don't have access to move the slide forward.
Yeah, it says you have access. Try clicking again on the slide. There you go.
Okay, we'll go ahead and get started. Thank you for having us today to talk a little bit about our work on reducing insulin adverse drug events at our hospital. The objective of our webinar today is to really evaluate insulin-related adverse drug events and the strategies that we've utilized here to reduce the number and the severity of these types of events. So we started to focus in on this project, and some of the reasons why we started to focus in on this project was that we were having an increased number of adverse drug events involving insulin. As many of you already know and are familiar with, insulin is a high-risk medication. It could cause significant harm if used in error. It's something that we had noticed around that time several years ago was that we had some inconsistent practices regarding our process for ordering and administering insulin, and even some lack of standard policies at that time as well. With insulin, it's a complex medication, so the aspects of prescribing, dispensing, administering, and monitoring take a significant amount of effort, and we realized that we wanted to help streamline that process and make it easier for our frontline staff to do this safely. A little bit about Nationwide Children's Hospital. We're a freestanding pediatric hospital located in Columbus, Ohio. We are now one of the largest pediatric facilities in the United States with over 600 licensed beds, over 18,000 inpatient discharges each year, and we see around 1.4 million outpatient visits each year as well. With that being said, our hospital also has a tremendous focus on safety and preventable harm. Our Zero Hero program started years ago, along with around the time that our Adverse Drug Event Quality Collaborative formed back in 2009, that was consistent of leadership in different areas around the hospital to really focus on how can we completely eliminate preventable harm to our patients as it relates to adverse drug events. So there's been a significant amount of work around the topic of reducing ADEs, but today we're going to be focusing on this presentation on really just our work around insulin reduction. Many of you are probably familiar with the categorization of medication errors. What's nationally utilized is the NCC-MERP index. And it's a categorical, starting with A through I categories that look at how harmful an error is. One of the differences at our hospital is we utilize the Nationwide Children's Hospital Clinical Severity Scale. So it's a numerical scale, very similar to the NCC-MERP index. However, we consider a severity 4 event an event that actually reaches a patient and causes harm. So on the scale, we categorize each medication error in our hospital from a category 1 being a circumstance or event that has the capacity to have cause harm, all the way up through severity 9, which would be an error that occurred that was followed by patient death. A lot of the events that we focus most of our attention on are those events that actually reach patient and cause harm, so the severity 4 through 9 events. So we consider a severity 4 event an event that occurred that was followed by increased patient monitoring or causing minimal patient harm or minor injury, a severity 4, because that might mean, for example, that a patient received a higher dose of insulin than intended, needed extra blood glucose obtained, and so that would be considered extra monitoring. Severity 5, on the other hand, are our events that maybe patient received a higher dose of insulin, became hypoglycemic, and needed a dextrose bolus. So they needed a temporary treatment or intervention as it relates to the event that occurred. And then you could see so on and so forth, with 9 being our highest severity event. The events that we were seeing ranged in terms of insulin, and I'll show you that in a moment, but 4s and 5s tend to be our more common types of events. So when we initially started our focus back in 2012 on this area, we looked at our hospital-wide adverse drug events, looking at severities, again, those harmful severity 4 through 9, or if you're familiar with NCC-MERP, D through I, and categorized it by drug classes, looking over the past 3 months from November of 2012 to January of 2013. And what we saw was that vaccines and insulin comprised of our top meds involved in adverse drug events. And so this is why this group decided to focus on insulin, and there was another group that decided to focus in on the vaccine errors at that time. So when we think about the common types of insulin adverse drug events that we see here at our hospital, they range, but some of our more common ones include wrong dose of insulin that was ordered, a wrong rate of an insulin drip, so rate was programmed in incorrectly, or IV fluids associated with an insulin drip were incorrect. Insulin pump was removed too soon, so we saw some errors like this. For example, in our emergency department, if a patient came in on an insulin pump, that maybe the pump was removed too soon before other insulin sources were available. We also saw some administration errors around insulin pens. We did move toward implementing insulin pens at our hospital, and those errors have significantly improved over time, but initially we did see some user error when we started that process. And then dispensing errors that can occur, so a wrong insulin, dispensing maybe Novolog instead of Humalog. So again, those are just some examples of some of the common types of ADEs that we were seeing around that time. So we decided to pull a core group of individuals together, an interdisciplinary group of individuals together to really focus on this insulin ADE effort. It was consistent of we had myself as a medication safety pharmacist, our chief of endocrinology, clinical informatics representatives, another endocrinologist that played a role on our team, along with our nursing colleagues. So we had our clinical lead and our manager, along with some of the bedside nurses that really helped us as well identify problems that were occurring. We included in our quality improvement coordinator to help us measure data and evaluate how we were going and trending in the direction of improvement. And then our chief residents were a part of our team as well. This team that started back in 2012 still consistently meets on a regular basis to focus on our reduction. Just briefly, I wanted to show you our key driver diagram. We initiated this when we started our project. I won't go through each of these areas, but mainly we set a goal to reduce our insulin adverse drug events, and we identified some of the barriers in doing that and came up with interventions to focus in on those areas. So I won't read through all of these now, but these will be discussed throughout the presentation, and we'll go into a little bit more detail into each of these areas. And now I'd like to turn it over to Erin Ahrens to talk about some of our focus areas and changes that we made in our electronic medical record.
So with great intention, we wanted to focus our areas on the clinician workspace in effort to cast the widest safety net for insulin dosing practices. And in order to do this, we really leveraged a few areas. We did focus on insulin dosing, educational opportunities and support, as well as the actual ordering process. And then subsequent to that, we wanted to make sure that wherever possible in the electronic health record, that we offered standardization of the practices, whether that be for our insulin pumps, labs, or nursing monitoring. We wanted it to be clearly communicated there for our practice standards. And then lastly, a big focus area of ours was, since the EHR serves as the ultimate communication tool for the patient's plan of care, we wanted to make sure that we leveraged templates for communication wherever possible. That way the communication was always clear and concise and standard amongst our clinician group. So first and foremost, we focused on our insulin ordering or insulin dosing practices. We are an Epic Systems facility. We are an early adopter of Epic. We've been on Epic since 2006. That being said, our institution predated the Epic released insulin calculator. So we do have a custom insulin calculator in our institution that has transitioned and been optimized throughout the years. However, we don't utilize the Epic released insulin calculator. A mainstay, though, of using a prescriber-driven insulin calculator in our institution is that we do require the insulin calculator be utilized prior to ordering by the practitioner mealtime dosing insulin orders. As well, it gave us the opportunity to ensure that we standardized bedside blood glucose lab attainment, and that was a big work of our group to ensure that point-of-care testing was available on all units. So speaking a little bit more about our insulin dosing and our insulin calculator and the electronic health record, it does leverage prescriber and nursing entered parameters, which is very similar to most EHR modeled insulin calculators. So our prescribers do enter things such as the insulin to carbohydrate ratio, the correction factor, the patient's blood glucose target, ketone correction, and the daily basal insulin dose. Whereas nursing provides the bedside parameters for the patient, such as blood glucose, ketones, and carbohydrate intake. What is actually different about most model released in the EHR insulin calculators is that at our institution, these two roles are actually reversed. So our bedside nurses actually enter the parameters first for blood glucose, ketones, and carbohydrate, and then our prescriber drives the remainder of the calculator to obtain a total insulin dose. This actually offers a final validation of the insulin dose prior to the transcription and order signing. So being that we are a large academic facility, we do have multiple trainee roles that are involved in the insulin prescribing process. Our endocrinology attending physicians, as well as our pediatric resident staff, have participated in an interactive learning module for insulin dosing, of which our medical education team developed that is a tutorial of how to utilize the electronic insulin dose calculator. Because we do realize that our residency staff may infrequently apply mealtime insulin dosing orders and utilize the insulin calculator infrequently, we wanted to ensure that they had just-in-time support for this infrequent occurrence. Therefore, we did leverage applying the link to the e-learning module directly in the EHR that's in the same page that they order the insulin dose from. We also wanted to mimic this same just-in-time education concept for our nursing staff. While we do try to aggregate our diabetes patients with insulin therapy management to one unit, we do realize that off-service patients, such as on our surgical services, could require diabetes management for insulin, and that nursing staff may not be as frequently familiar with diabetes management or how to document bedside glucose, ketone, and facilitate the ordering process. Therefore, we've leveraged standard nursing resources and references via hyperlink on the nursing landing page when they log into the EHR. Given that insulin is a high-risk medication at our institution, we do leave this education tool static on the nursing landing page so they always have a place to reference this information. Through investigation of other errors that we've had with insulin management, we did want to take opportunity to leverage a few other electronic health record tools. Most institutions, such as ourselves, have developed standard order sets or templates of orders that leverage groups of orders to promote standard practice. We've actually made ours department-based. So for our insulin and diabetes patient management, we have specific order sets available for our ED, our ICU, and then our non-ICU inpatient units. We try our hardest to utilize the same groups of orders within each so that this increases prescribers' aesthetic understanding of the information and reduces variation for them in how they use and see these orders. We also identified that the transition of these patients from the ED to an inpatient admission often requires increased communication regarding the plan of care. Given that the ED often has more of an acute process in their management of the patient, we wanted to make sure that the inpatient staff was fully aware of everything, all the interventions that were applied in the ED and what the plan of care was in transitioning to the inpatient. So we did create a templated text of information to ensure all the clinically relevant information was clearly communicated. And then lastly, we noted that sometimes our off-service, i.e. non-endocrinology admitted patients, will still require diabetes management through insulin therapy orders, and we wanted to ensure that consultation was quickly facilitated to our endocrinology service. Therefore, we've created an automated order tool that does look at the patient's history of diabetes and prompts the prescriber to place a consult to endocrinology automatically upon ordering insulin therapy. So next we're going to speak about our focus area of the actual insulin ordering process. So unlike some institutions, we do not utilize a standard continuous sliding scale order for insulin. Rather, we have our prescribers place once orders for mealtime insulin dosing. In order to facilitate this and facilitate all the combined management monitoring labs and nursing communications required to do this safely, we wanted to leverage an insulin order set. We therefore opted in our institution to remove all insulin products from our quote-unquote a la carte ordering. So prescribers are required to actually use the insulin order set to place insulin orders. This actually made it very easy for us to leverage and mandate all the other templated orders for insulin management. We also do have several other order sets for patients with diabetes, such as a new onset and a DKA order set. Again, this helps us ensure those standard practices are met via templated ordering. So more specifically about our insulin order set, again, that's where our prescribers are driven to when they need to place a mealtime insulin order or a once-dose insulin. We did template all of our nursing communication orders about how and when to notify the practitioner for an order. We also developed standard groups of orders for hypoglycemia interventions that nursing can act on very quickly with very specified parameters. And then also to ensure and streamline the communication with nursing to the practitioner for mealtime dosing, we also have very clear explicit orders for obtaining blood glucose just prior to the meal. The insulin orders available in the order set are then grouped by short-acting, the supplies, mid-acting, long-acting, our pumps, and our drips. This actually decreases prescriber variation in order placement and actually increases their decision support in accessing the orders quickly and easily. And then lastly, we ensure that we panel together all of our point of care monitoring and our labs that are necessary to be placed on these patients. We do have additional logic or rules embedded in the lab and monitoring panels that automatically default the placement of these orders if they are not already placed on the patient's medical record for this encounter and the patient requires insulin therapy. Speaking a little bit more about the insulin order set, Dr. Camboj will get into a little bit more about our transition from vial to pens. However, our insulin order set does offer only 3 short-acting products and the 3 mid to long-acting products, again, templated and grouped in our order set for prescriber efficiency and convenience. And then to speak a little bit more about our DKA order set, we really found opportunity to strengthen our standard practices through this order set by mimicking our clinical practice guideline within the order set. We did create standard 2-bag system fluids that are automatically default applied together, which strongly decrease variation in prescribers inadvertently combining fluids that would be mismatched to run with the insulin drip. We ensured that our ED, our inpatient non-ICU unit, and then our PICU unit all shared these same grouped panels to make sure that the patient's clinical workflow from ED to admission was efficient and that orders were not duplicated or erroneously discontinued. Additionally, because our DKA patients require additional monitoring and frequent monitoring, we ensured that we instilled all that in our order sets. And then lastly, we did find, as Jenna spoke, some errors within our ED population, of which sometimes the pump was inadvertently removed too early in the patient's care, and we did not have our insulin drip or other insulin therapy started on our DKA population. Therefore, we went ahead and inserted an algorithm for decision support management for our ED prescribers into the order set so that they could identify where in the patient's point of care that they should remove the pump and then allow nursing to facilitate starting of the drip.
So as it's apparent with my 2 excellent presenters, what they've said already, the theme in decreasing the insulin-related adverse events seems to be standardization, 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 in addition to improving communication. So these are sort of the 2 main and important things which are sort of the theme in everything that's related to insulin administration. So continuing on that and detailing a couple of more of these things, we have standardized procedures across the ordering profile here. So lab testing, transition from insulin vials to insulin pen usage, inpatient insulin pump usage, meal delivery times and carbohydrate content, and then the endocrinology consultation for all patients who would not be admitted under endocrinology otherwise. So prior to an insulin order being placed, there are 3 main parameters that need to be known and available for accurate insulin dosing. You need to know what the blood glucose level of the patient is at that time before a meal. You need to know how much carbohydrate the patient wants to eat in that meal, and what the blood ketones are if it is indicated to be done in that situation. The process here we found initially before our processes were in place would sometimes take forever because initially the blood glucose had to be drawn and sent to the lab. The urine or the serum sample had to be sent to the lab for ketone testing, and usually took more than well over an hour, which meant that the insulin dosing got significantly delayed. So a lot of our effort went into standardizing and then making available point-of-care testing so that we have this information available within minutes. So we do a blood glucose right in the patient's room. We do a blood ketone right in the patient's room, so we have that information within a few minutes. We also have the meal available, and we'll talk about that. So all this information is known within minutes and is communicated to the provider for obtaining an accurate insulin dose. We also transitioned over the last few years from using insulin syringes and insulin vials to using insulin pens. These are some of the pens that are commercially available and are used, so we focused and honed in only on a few of these to avoid confusion again. The significant things were that half-unit insulin pens were available, so that facilitated taking care of half-unit insulin dose dispensing for our younger patients. These devices are much more convenient to use. Some of our younger, not so young children can actually use the insulin pen for themselves much sooner than they were able to use the insulin vials and insulin syringes. They were more cumbersome. The needles available on the insulin pens are much smaller, so it is much more patient-friendly and kid-friendly. And of course, everybody really enjoys using the insulin pens much more. The second thing was initially we were teaching patients insulin syringe use and then sending them home, and then on a subsequent visit, they were transitioned to insulin pens, and that required another teaching session. And a lot of learning, as it is very cumbersome for a new family and patient to be educated for insulin and diabetes care. So that really took away that whole second visit where the transition had to occur and facilitated, and really was a big patient satisfier. We looked at all patients who were on insulin pump therapy at home, and if they had to be admitted to the hospital for an episode of diabetic ketoacidosis, we actually ended up either changing them over to subcutaneous insulin, or they would be using their home pumps, insulin pumps. Both these were big dissatisfiers for one reason or another. If a patient who's using insulin pump at home had to be switched over to subcutaneous insulin therapy, they were very unhappy at having to do so. And on the flip side, if we kept their home insulin pump on, that was a source of potential error because there are several insulin pumps in the market, and it is kind of humanly not possible to keep up with the technological advancements in all these devices on almost a continuous basis. So we decided to adopt a standard insulin pump for use on the inpatient service. So we have standard insulin pumps that we have that each patient is switched to this hospital pump. Our personnel are trained on these hospital pumps, so they are very familiar with these hospital pump devices. And therefore, the errors that we had with having personnel having to use different devices were eliminated. So our nursing is very familiar with these standard pumps, and all patients now admitted are switched over to the hospital pump as they come in, and as soon as they're ready to leave, they're switched back to their home pump. So that has worked really well. In addition, we limited the use of insulin pumps to standard designated specified units. So the endocrinology unit, a couple of the cystic fibrosis related diabetes units are the only ones that can use the insulin pumps. So that limits the personnel that need familiarity with these complex devices as well. So thus minimizing room for error. And as Erin and Jenna alluded to before, this is sort of that pathway that you're looking at for the usage of the insulin pump. So we don't expect you to read this fine print on this pathway, but basically it walks a provider through when is it best to remove the insulin pump in the emergency room or on the inpatient floor after they meet these criteria. So it's very, very easy for providers to look at this, and this has been very helpful in preventing premature discontinuation of insulin pump in situations of DKA in the emergency room. Next.
Slight delay in the slide change.
Sorry. Another area is the meal delivery times. So we standardized the meals to be delivered to patients with diabetes at a specific time for breakfast, lunch, and dinner. And this has been tremendous in reducing delays resulting from receiving the meals from the hospital provided services, and has been a big satisfier for patients because they expect and do receive the meal at a particular time. Also, we standardize these meals so that they come with a list of carbohydrate content for each of the components of the meal. So it is very easy for the nurse and the patient to be interactively involved in discussion and adding up those carbohydrates that are documented right on the meal tray, and is good for learning and also for accuracy. The meal tray is delivered to the nursing station, and the nurse ensures that everything is ready, and then takes the meal tray to the patient's room and gives them the insulin injection and has the patient start eating. And as was alluded to earlier, we felt that the endocrinologist's familiarity with either the patients who were admitted or just familiarity with diabetes and insulin was kind of key in having patients get their insulin safely. So any patient who was on insulin therapy and had to be admitted to a non-endocrinology service, such as surgical services or psychiatric services, etc., there is a mandatory endocrinology consult that is in place, and these providers are encouraged to actually do a phone consultation immediately so that the endocrinologist can walk the other services through what the accurate insulin regimen and dosing should be. And this is only for patients who are on non-endocrinology inpatient services. So the second piece of improving insulin delivery is the communication piece. So as you already see, there are multiple steps in getting an insulin dose ordered, so much more complex than from 20 years ago. And therefore, the communication efficacy and efficiency is very, very important for timely and accurate insulin dose delivery. So how it runs at present is we have the blood glucose tested, and it transfers automatically to the electronic medical record. The carbohydrate content in the meal is entered by the nurse into the electronic medical record. And then the RN informs the prescriber, generally a pediatric resident who is on the endocrinology service, that an insulin order is needed via a text page. And the insulin orders have all been designated to be high priority, so they kind of bypass the queue and are on top of the list to be ordered immediately. And if the RN does not receive an almost immediate response back, there's a process for escalation of the process so that we try very hard to make sure that the insulin dose is administered within the 60 minutes. And actually, if it is a minute or two over, it does become an insulin-related error that is recorded.
Now I'd like to walk us through a little bit of the data review, how we measured our adverse event rates. And so starting out with the first chart, it looks at our insulin adverse drug events, and it's looking at the higher severity events, so severity 5 through 9 per 1,000 doses administered. So we utilized a control chart to look at from our baseline in 2012 through the intervention period of 2013, where we were implementing a lot of the interventions that we discussed through 2016. And so initially our baseline error rate was 1 ADE per around 1,600 doses of insulin administered, and that went to 1 ADE per around 3,600 doses of insulin administered. So though you can't see a drastic decrease necessarily on this graph, it was overall a 56% improvement from where we started to where we were at the end of 2016. Looking ahead at the next chart, other ways that we were able to look at adverse drug events included looking at the administered doses between. So looking at our desired direction in this graph is higher. So looking at severity 5 through 9 insulin-related ADEs, we wanted to look at how many times there was an ADE compared to the number of doses that were administered. So in this, you could see the stair-step approach that increased over time from 2012 to 2016, where we were able to give, by the end of 2016, around 3,200 doses of insulin without a medication error occurring. And again, you could look at ADEs in a variety of different ways. Each hospital does it slightly different, but this allowed our team to have visibility as to the interventions that we were implementing, how well we were doing in process with those, and was it impacting our overall ADE rate during the process. Something else that we wanted to look at our hospital was the insulin ADEs overall, so severity 1 through 9, so even throwing in the lesser severity insulin events as well. This shows more graphically when we implemented a variety of those different interventions that Aaron and Dr. Camboge had discussed throughout their portion of the presentation. But again, you could see over time the error rate going down from 2014 to 2016 over a period of time. Another aspect that we focused on was the days in between. So calendar days in between is another way that you can look at severity or your adverse drug events. And so we looked at this in terms of 1 through 9 events, and then also in our 5 through 9 events. So we wanted to see, our goal was to see higher peaks in between the number of days that the events would occur from when we started to what we've implemented. So we started focusing even more as of recently on those severity 5 through 9 events and putting more of our efforts to the 5 through 9s and really closely evaluating those. And you could see through the end of spring of 2017, we've even included in here, we've gotten up to around 185 calendar days without a 5 through 9 adverse drug event as it relates to insulin.
So as you quite well see in all this data that here, I think there's been a lot of effort made at multiple interventions, and I think we have seen tremendous progress in what we were able to achieve as far as decreasing these insulin-related adverse events, whichever way you kind of measure them. As next steps, we continue to aim towards improving further, of course. We would like to improve the insulin ordering in our outpatient clinic setups as well. All this work has been primarily inpatient focused. We would like to evaluate the newer versions of the insulin dose calculator. The insulin dose calculator we have at present, it's felt to be tedious, a little more cumbersome to go through, and definitely there is room for making it more user-friendly as well. We would like to develop clinical decision support for insulin ordering in our peri-operative hospital areas, and that's been one part of the hospital that we have not focused on thus far. And we would like to continue to remain transparent with our insulin ADE data. And all this has been kind of been out there. We have been very, very transparent thus far, and we continue to aim to do so. In conclusion, we would like to acknowledge that a combination of an enhanced safety culture in the institution, non-punitive medication huddles, and the structure of our team, which is multidisciplinary, has all contributed to reducing these insulin-related adverse events at our institution. We also feel that engaging with frontline staff on developing interventions greatly improved adoption of new processes to improve patient safety. So there was a buy-in right at the grassroots levels, and I think that's a very important piece of making these endeavors successful. Thank you. And we would be happy to take any questions that you may have.
Okay, if individuals will either, they can go ahead and answer questions. Let me share.
So it would really help you to.
Okay, everyone is unmuted, so you can just go ahead and directly answer, ask your question.
Where maybe large out a patient guide or it's not, and we do about where you like share challenges and maybe the possible outcomes or costs. I have a question in regards to the use of the insulin pens. Was it a hard conversion to try to, convert from the bottles and the syringes to the pens, or did the clinicians find that, much easier to use and much less error prone?
So we were actually already utilizing individualized patient vials before this. So I know there was a lot that came out in the ISMP, from different safety organizations just regarding how can hospitals do this conversion safely. But at our hospital, we were already utilizing the method of only a vial for a patient, so patient-specific vial. So when we switched to the insulin pen, it really didn't, we didn't have the safety issues, or our nurses were already used to that method of only using, a pen per patient. And they were doing that same thing even when it was a vial. I think there was some nuances in terms of teaching, from how to prime an insulin pen and some of the nuances with how they function. or when they malfunction, what to do. But once the techniques were trained, I think that our frontline staff that were administering really caught on quickly to the concept, and it's allowed our patients to learn how to give their insulin doses on the inpatient side, is doing that on their own once they're in the outpatient world.
Thank you. And then one more question, in regards to increasing communication and, engaging the emergency department staff and, maybe a better handoff. Was that a challenge, trying to facilitate a smoother flow of information, from the ER to the different units? And what did you find worked best in looking at that process specifically?
Yeah, so we actually would engage when we were working on areas, for example, like removing the insulin pumps, or some of our nuances around DKA. When patients come in and DKA, we actually engage them and would invite them to our insulin ADET meetings. So we had representatives from there. At times we pulled in representatives from our PICU and other areas of the hospital, so that we were able to really talk through what our processes were in the different areas. And I think that engagement allowed the communication to open up a lot more with those different areas around the hospital.
Thank you.
Mm-hmm.
Any other questions?
Higher level quality study.
Thank you all for having us.
Stacy, that can be a place where an organization.
If there's no other questions, I want to thank everyone for attending, and thank you especially for Nationwide Children's for outstanding presentation. This really was very informative, and I think it can really help reduce insulin errors across all hospitals, not just the pediatric hospitals. So I'm really appreciate your thorough presentation. With that, we will end the program, and we'll conclude it. Thank you.